In this portion of your PowerPoint slides, we're going to be talking about myasthenia gravis, multiple sclerosis, ALS, Guillain-Barré, cerebral palsy, trigeminal neuralgia, and Bell's palsy. With multiple sclerosis, I think it's one of my saddest neurological disorders that we'll talk about. It is the chronic progressive degeneration of a disease. So they just constantly get worse and worse and worse. It actually attacks the protective of that myelin sheath. It could cause numerous physical and mental symptoms, often progresses to physical and cognitive disabilities, and then it's the one that you may have come in contact with. They're young females, and they may not know that they have any problem at all, and all of a sudden in their 25, 35-year-old, middle-aged, younger-aged females get multiple sclerosis. They have attacks of remissions and exacerbations, so you'll hear them say, oh, I have good days and I have bad days. We don't know the cause. It does not actually affect life expectancy. It just continually gets worse, and physically gets worse, and cognitively it gets worse. It is an autoimmune disorder, so the body is attacking itself, so that's why we don't know why all of a sudden the body just turns on itself. They'll have visual problems, problems with coordination, bladder problems, spasticity, and of course depression, because it's like your brain and your spinal cord can't communicate. Both of them work, but they are not sending the message and receiving the message appropriately. So it's a very depressing disorder. With a medical diagnosis of multiple sclerosis, we look at the cyclic exacerbations, remissions. Does it get better? Does it get worse? Does it get better? Does it get worse? And eventually then the person does have an MRI of the brain to see if the plaque that is characteristic of MS is the plaque that's laying down in their brain. As far as treatment, we try to give them some steroids, some immunosuppressants to calm down, because again, it's autoimmune. Something for the pain, some antispasmodics to try to make them feel as good as possible, but a lot of interventions are just promoting independence, good range of motion. The patient's on immunosuppressants, which can actually increase risk for infection, so we worry about subsequent infections. We especially worry about them like right now with COVID and everything. It would just be very devastating to a person with MS. Be alert with any they could have problems swallowing and urinary retention, and they will be completely dependent someday on all care. Myasthenia gravis is another autoimmune disorder. It's actually the thymus gland is responsible for production of antibodies, and we're just not getting that stimulation. We just don't get the message. So the muscle becomes exhausted, the muscles don't contract at all, and the person becomes just completely flaccid. That's why your sign symptoms here is the weakness of involuntary muscles, chewing, swallowing, speaking. They can have ptosis and diplopia, so eye movements and double vision. It's fatigue. Fatigue is kind of that hallmark sign of myasthenia gravis, so they just don't have the energy or the desire nor the muscle capacity to do anything. With myasthenia gravis, the good news is that we actually have a very specific test called the Tensilon test, where it is actually to administer a material called Tensilon into the muscle to see if the muscle tone actually improves. So can this material or outside substance cause your muscle to improve the muscle tone? If it's muscle tone within a minute, and then does it actually maintain its tone for 4 to 5 minutes afterwards? The other, as far as that's kind of the gold standard for myasthenia gravis test, treatment, we could do some medications, we can do some steroids, possibly a thymectomy, which Typically, the thymus gland begins to grow at birth and then after until puberty, so it continues to grow, and then after that it actually decreases. And so since this is a thymus problem, then what happens is a lot of times people will just have their thymus removed, and hopefully that will help get rid of a lot of the signs symptoms. They may also have plasmapheresis done. Plasmapheresis is where they remove their antibodies. Since it is autoimmune and their body's attacking themselves, they will actually have blood drawn and basically donate blood, and then have those antibodies removed with it. Um, and they can't use that blood for like blood banking or anything like that, but they're trying to remove those antibodies, and then they'll give them actually back that unit of blood. With your assessment, you need to find out a full health history, what the symptoms are, were they doing anything at the time of activity? Do they have the diplopia, the dysphagia, slurred speech? Are they having any kind of balance problems or breathing problems? So that will help us with our assessment of what's going on and how far their myasthenia gravis has gotten. Nursing interventions monitor for breathing. Again, respiratory is a muscular response, and if this person is having a general muscle issue due to a neurological problem, then we need to make sure that we're doing all of our interventions for breathing, turn reposition, soft diet, small meals, and the last part here is that if they have a myasthenic cholinergic crisis, this is an emergency situation with suddenly difficulty swallowing or breathing. So what happens is the Tinslin test will be used to distinguish from this. If there's a rapid improvement in muscle strength, there's a crisis, the myasthenia crisis. So they're not on enough meds to control their son's symptoms. If they have no improvement in the muscle and all of a sudden the swallowing and the breathing, they may be on too much medications. So it's a fine line here as far as treatment. But anyway about it, this is an emergency situation because they are suddenly having difficulty swallowing and breathing. ALS, or also known as Lou Gehrig's disease, which is actually a famous baseball player that had this. And so it's a progressive, usually fatal disorder where it's caused by the degeneration of those neurons and the nerve cells in the central nervous system that control those voluntary muscle movements. It is, like I said, it is a viral suspected, but we don't exactly know why all of a sudden people get ALS. The cognitive function is usually spared. So that's the horrible sign of ALS here when you're going through your signs symptoms. It's weakness of voluntary muscles, it's difficulty swallowing, speaking, eventually respirations become shallow. But think about your body is failing you, but your mind never did. So you're trapped inside a body that doesn't work. And that's the cold hard truth about ALS until you die. So cognitively, you know that you're having difficulty breathing, but you can't say it. Cognitively, you know that you can't move your arm, or your arm hurts, but you can't get that expression out there. It's usually what happens is death results from aspiration or repeated respiratory infections. So a lot of times they end up drowning in their own respiratory secretions. With ALS, the medical diagnosis is based on a history and physical. We do need to note that when we're diagnosing and treating ALS, they're very prone to depression. So we need to address that. I can't imagine being trapped in a body that is failing me. There is no cure. We just do supportive treatment and focus on preventing any complications, maximizing any kind of function that the person has left. So we need to be with them as long as we can and try to take care of them the best we can, because the muscle weakness, those atrophy of muscles, the spasticity, they're getting just worse and worse and worse. With a person with ALS, they're going to need, you're going to need to monitor their respiratory status, making sure, again, suctioning equipment is as needed and is at the bedside. CPT is, remember, that chest physiotherapy, that postural drainage, percussion, vibration. Oxygenation here, head of the bed elevated during meals, possibly texture of meals. They have a problem swallowing, possibly feeding tubes, altered communication, so somehow maybe have them blink for 1 for yes and 2 for no. Look at their skin and emotional support, because again, this is just a devastating disorder to both the family and the patient. So Guillain-Barré is a disorder that I actually posted a really interesting picture about. It's on the rarer side, but it is, again, it's a very unusual disorder of how it works. We don't know why all of a sudden. Usually they have an autoimmune response again to a viral infection. Most often this is an upper respiratory infection. So a recent upper respiratory viral infection, and now they're getting these signs and symptoms that is destroying the myelin sheath, which slows the nerve conduction, which gives them very specific signs and symptoms. With Guillain-Barré, you can see this is what makes it so unusual. It has an initial phase of muscle weakness. They may have chewing problems, may have lack of facial expression, and then this particular one actually starts distal and moves towards the top. So at mild paralysis in the feet, hypertension, orthostatic, profuse swelling, urinary retention. It gives you a wide variety of signs and symptoms here. Then possibly including an increased pulse rate, adventitious breath sounds. They could need suctioning. It's kind of a wide variety of issues here, like I said. Then as this disorder, it in the initial phase, it has a symmetrical muscle weakness. So it begins in lower extremities and ascends toward the trunk and the upper extremities. So the weakness progresses upward, usually over the periods of hours to days. Then the arms and the facial muscles also become affected. So what happens is all this initial phase, that this weakness is actually ascending over your body, and then it has a plateau, which means that it's no further neurological deterioration, so it just kind of stops. And it doesn't get better, it just plateaus. And then you have the paresthesia in the hands, the feet. It depends on where it plateaus. I particularly knew a lady who had this plateau just right around her umbilical region. So basically everything under her belly button was numb, and everything above her belly button was okay. And then a recovery phase. So what actually happens here, that plateau phase can actually happen or last for about 2 weeks. Then the recovery phase. So your body will actually repair itself, and the muscle strength returns proximal to distal. So whatever it actually started with her belly button and moves right down to her feet. That recovery phase, though, can last 4 to 6 months. The medical diagnosis of this is actually the heuristic of the pattern in the ascending motor. Nothing else, no other disorder that we know of actually starts in the feet and works toward the head. That's just actually, it's unusual to it. The other thing we can do is elevated protein levels. So we check the cerebral spinal fluid via lumbar puncture, and then we can actually check an EMG to reveal see if the conduction studies, see if the electrical stimuli and where it's going to plateau. Then treatment is, of course, monitor respiratory status closely. If we get anything above the diaphragm, we really worry about respiratory status and breathing issues. We give them steroids. Again, we do that plasmapheresis because it is autoimmune. And so the blood is removed, centrifuged, removed any of the antibodies, and then given back to the patient. Turn reposition, make sure there's safety, feeding precautions, maintain an airway, and it will get better. They're just kind of stuck like this for momentary of possibly up to 6 months. With cerebral palsy, this is a non-progressive disorder, meaning the brain damage does not worsen, but it is a secondary orthopenic difficulties are pretty common here. So there is no cure for cerebral palsy. We just focus all of our treatment and interventions on maintaining function. Mental function can vary, and it is often a birth or developmental factor, so you'll find cerebral palsy also in your pediatric book. There is 4 types of cerebral palsy. Could be spastic, which is movement, athoid, which is involuntary withering or shaking back and forth, ataxic, which is uncoordinated movements, and mixed, which is a combination of all. Now, I do want to stress that this is not mental retardation. Cognitive function is not usually impaired. This is sheerly a neurovascular response that is causing the muscles to do spasms and withering. With cerebral palsy, we aim, and I know it says aimed at assisting the child to make the most of their abilities. It does start, like I said, it is a pediatric disorder that goes into adulthood, and so we want to make sure that we teach them everything that we can to get not better, but to maintain the function they do have. We want to provide meticulous skin care, any kind of braces, walkers, wheelchairs that are possibly could be needed, assist with feeding, whether that's a feeding tube of a lifelong feeding tube, and muscle training and exercise. With trigeminal neuralgia, what this actually is only in the face. So you can see the trigeminal nerve here, since you're going to study your cranial nerves, and so you do have the trigeminal nerve here that goes across the ophthalmic, maxillary, and mandible regions. And so what has happened is the irritation of that trigeminal nerve from a variety of reasons. Could be irritation or compression. I've actually had an earache that caused a trigeminal neuralgia. So intense pain on the side of the face. It is to the forehead, the cheek, the nose, the jaw. Recently, whenever I had my tubes put in, I had a severe ear infection, and the eye drops actually caused me to stimulate this trigeminal nerve. And whenever they say intense pain, it's like your face is on fire. Diagnosis by history and physical, just looking at it, or just, you can't tell anything but look at it, but it's just a pain that described where that right across your forehead, right here underneath your eye, and by your chin here. They can always do a CT and MRI to rule out anything else. Interventions would be obviously to fix whatever the irritation is, but if it's a chronic compression issue, then anticonvulsants, possibly a nerve block, which would block the signal, and even surgery to go in there and actually block the signal that the nerve is releasing. And last but not least in this section is Bell's palsy. It's actually inflammation, the edema of the facial nerve. So again, we have another facial nerve issue here. Loss of motor control. What makes Bell's palsy very specific is that actually it's one-sided. So they'll have pain, weakness, speech difficulty, drooling, tearing of the eye, inability to blink only on the side, because that is only where the facial nerve is affected. So you can see a picture here of, the eyeballs and the facial problems. Diagnostics is on history and physical. We'll check and make sure that it is the facial nerve with this electrical study, and we need to rule out a stroke because it does look very much like a stroke. The pain, the weakness, the difficulty speaking, drooling, but with a stroke they typically have the generalized weakness on that side of the body. This person, the body is fine, it is just the face. So therapeutic interventions would be prednisone, analgesics, some antivirals, gentle massage. They even include a facial sling, which actually could help with the drooping of that side.